All right, so pharmacist interventions part 18. So today I had a patient who's prescribed a Flovent inhaler, and he was kind of older. So I always like to ask like what your diagnosis is, because usually they will prescribe like steroid inhalers for patients with asthma. I'm not saying that older patients can't have asthma, but they usually have COPD. And this patient did have COPD. He wasn't on any other inhalers, and I talked to him about how he needs to follow up with a pulmonologist. He said that they already recommended that. The prescription was from a resident physician from the hospital across the street, and I recommended, of course, following up with the pulmonologist, because usually you don't give like a COPD patient like an inhaler that is usually used for like asthmatic patients, a steroid inhaler. We'll use steroids sometimes in COPD patients if their eosinophils are elevated, but based off of what type of COPD they have via the GOLD guidelines, we usually give them like a LAMA-LABA combo, like a Noro. A long-acting muscarinic antagonist and a long-acting beta agonist. That's usually what most patients are on, because steroids can increase the risk for pneumonia. So we don't usually give those like first line for COPD patients. Another intervention that I've had recently was a patient on a Totolac as well as Celebrex. So they're on two different NSAIDs. We have a non-selective COX inhibitor and then a COX-2 selective inhibitor. Celebrex is usually used for like osteoarthritis and stuff. But I figured out it was two different providers prescribing it, and I think the patient was like taking both of them for like a short amount of time. But they didn't know that they were like in the same drug class. You're not supposed to be on two NSAIDs. That's very bad, of course, with the warnings of renal or kidney problems, ulcers, cardiovascular risks, stuff like that. I had another patient who's picking up Lipitor 80 milligrams, and it was flagging against his Genvoya. He's taking Genvoya for HIV, inhibits the metabolism of atorvastatin, and he was plopped on the max dose. He was previously on 40, which also was too much. Usually if you're on like a concomitant enzyme inhibitor, you want to be on maybe 20 milligrams max. So I counseled him on like muscle pain. I told him that I wasn't recommended. I sent a fax to the provider and recommending like a CPK, like a lab, to see like, is it breaking down his muscle, because he was already on like twice the maximum dose that was recommended for someone who's on Genvoya. Another pharmacist intervention, I had a patient who had some really bad dry mouth, and I figured out it was their dicyclamine that was causing it, antimuscarinic. And then lastly, another intervention or like, I guess, discussion I've had with a patient is a patient who is on two antimuscarinics for some reason, dicyclamine and hyoscine. So I counseled on duplicate like antimuscarinic therapy, like confusion, like maybe sort of dry mouth, constipation, and urinary retention. He also had a diagnosis of BPH, or benign prostatic hyperplasia. So the duplicate, or I guess dual antimuscarinic medication therapy is probably not the best for someone who has urinary retention.